So with that, I'll start the class. The basic question in any IR procedure or any procedure that we do has to start with patient selection as to who should get the procedure and who should not. That is a very important part that most places miss and is a question mark in most IR training programs because you do what is referred to you by somebody and you kind of go ahead with it because it has been asked or it has been sent to you, but the patient selection is your responsibility. It is not the responsibility of the person referring the case. So the next thing is again preparation pre and post, what material we should collect, what is the types of cements that we have, which is the one we're using in vertebroplasty, what instruments you use. Actually, it's a very uh, friendly procedure in the sense that not too much of instrumentation is required. A simple bone biopsy, needle, and cement is perhaps the uh, procedure. That's all that's required, apart from a bit of local anesthesia. Of course, you need a nice fluoro or a cath lab, that is good. But of course, the otherwise the requirements for the procedure are quite low. Complications is the important thing here because given that we can't really open the patient up, and if we get the cement in the wrong place, then we sometimes are dependent on the neurosurgeon to kind of do. That's why it's a bit difficult to have people practicing vertebroplasty from our side outside, because some of the neurosurgeons, some of the orthopedicians are also doing this procedure, and then finally it goes to, definitely the theory question is there on this exam. Actually, one of my professors only has a very soft point for this, and they are usually the people who set up the exam, and that's why a few of these questions have come in for vertebroplasty specifically. And it's a musculoskeletal interventional procedure, so of course you can it might be a part of the question if it's asked in how intervention radiology is useful in musculoskeletal diseases. So that's also an important area where this will be useful. So we'll and the last part is of course for those who are CR here not just for the exam but also to understand where we are in radiology, because not everything is about the exam. Some part is because you want to learn the newer things and best things that are there outside. So we will talk about the current evidence as to is it useful, and some of the newer techniques, what are the developments that are happening. So the basic idea is the two traditional techniques in vertebral augmentation procedure are vertebroplasty and kyphoplasty. So vertebroplasty is the one which we are discussing. It was the first one that was brought in, and then they started using a balloon, inflatable balloon, to kind of create more space so that they could fill in more amount of semen and help increasing the height of a collapsed vertebra. So if the vertebra is significantly collapsed, then to reinstate a bit of height, they started doing kyphoplasty. So difference between vertebroplasty and kyphoplasty is before injecting the cement, we create a bit of space by inflating a balloon in kyphoplasty within the vertebral body. You go into the vertebral body and then you inflate the balloon, then deflate it and you come out. Then you inject the cement. Both are minimally invasive. We don't make any cuts. It's all percutaneous, and they are used for treatment of vertebral fractures. So this was the initial times when it was started for vertebral hemangiomas. Actually, it was started as a treatment for vertebral hemangiomas, painful vertebral hemangiomas, basically to control the pain. So because of the cement that went in, the exothermic reaction that happened because of the heat produced by the cement, it used to help the patient and the pain used to get reduced. The indications now, current indications are osteoporotic vertebral fractures, of course, chronic fractures more because the normally the osteoporotic fractures with correct support mechanism and good rest and good pain medication, they usually do well in 7 to 8 weeks time. But if the patient is not improving, is not able to bear weight despite prolonged rest, because then the time for which the patient is undergoing this resting period starts creating a problem, because these happen in old patients. An old patient who is immobile for a very long period of time can then just spiral into the wrong direction, DVT, bed sores, further bone weakening because you're not using, not loading the bone, so osteoporosis worsens. So all those things are the reason why if it's not happening within the first 4 to 8 weeks, we might help the patient by doing vertebroplasty. And we see usually if it's not healing because of the imaging findings, stir hyperintensity being there, or the patient's clinical conditions are not improving. The second part is symptomatic hemangioma. As I just said, painful hemangiomas can also be an indication for vertebroplasty, though now we also have possibilities of embolizing, but sometimes you may take care of the vascularity, or the vascularity is coming from an artery which is also giving rise to the spinal artery. So then you're in a fix. You can't really go the embolization route as there is a risk of spinal ischemia. So there's again another important use of vertebroplasty. Then third is painful vertebra secondary to malignant. So one was osteoporotic, second is a malignant fracture or malignant involvement of the vertebra, and sometimes in traumatic fractures. So usually traumatic fractures, if there is too many segmentation or there is too much displacement, of course, it needs open surgery fixation. But traumatic wedge fractures, which have no significant displacement, then in those patients, and if they are not improving, they are having pain, conservative treatment is not helping them, then you can go for vertebroplasty. So these are few images showing when we treat. So this is residual edema. Patient has pain, and you can see in stir that there is significant edema in the vertebral body that suggests that there might be pain. The other thing is you can always also figure out how whether it's a osteoporotic fracture or a malignant fracture, and because osteoporotic fractures would have the fatty marrow, whereas the malignant lesions will have the infiltration of tumor. If there's fat on the opposed phase, there will be fall in the signal intensity. So this is the where is the pointer? Yeah. So this is the opposed phased image and this is the in phase image. You can see that significant drop is there in the intensity. This is 667, this is 106. So usually 20 to 30% drop between in and opposed phase suggests that there is fat. So this is significant suggestive that this is fatty and more of osteoporotic fracture than malignant fracture. This is one way of differentiating. This is the typical hyperintense cleft that we see more in osteoporotic compression fracture. You can see here this hyperintense cleft. This is the fracture line and it is still hyperintense on T2 and star, and this is suggestive that there is still inflammation and the fracture line has not healed. Again, this is, you can see here, not much fall. This is 475. Sorry, in phase is 437 and post phase is actually slightly higher or almost similar. So here, this is a more of a malignant fracture. This is soft tissue that has involved the vertebral body and not just a collapse of the vertebral body with fatty marrow being there. So these are some of the signs where you can pick up malignant versus osteoporotic, healing, non-healing. So those cleft signs, the edema that is there on star, these are suggestive of. So the non-healing signs can be because of the edema and the cleft. And you can see the in and the post phase images where the in phase would be, the opposed phase will have a drop of 20 to 30% in case of osteoporotic fracture. So these are the things you need to remember. So we have indications. The other thing that you need to know is contraindication. So if the patient's symptoms are improved, don't go after the imaging findings. Then the patient stays on conservative management or asymptomatic. If you find a vertebral fracture, you don't have to go and say, I'll do vertebroplasty. Okay. So that is there. And then the third is tumor mass with the spinal canal involvement. So in those cases, again, if you try, because the posterior cortex has breached, it has gone to the spinal canal. Now, if you inject cement, you might end up pushing the cement back into the spinal canal because there is a breach. If there is soft tissue that is going into the spinal canal, the cement can also go. So you don't kind of go there, and anyways, that patient will require surgery to get rid of the mass effect. So it's better